With that, it is my tremendous pleasure to introduce Dr. Jason Zucker, who's Assistant Professor of Medicine in the Division of Infectious Diseases at Columbia University and Assistant Medical Director of the New York City STD Prevention Training Center. He's a med-peds trained physician and has extensive experience with HIV treatment, HIV prevention, and sexual health care, and providing status-neutral care to patients of all ages in the New York Presbyterian Columbia Comprehensive Health Program Sexual Health Clinic. He's really interested from a research standpoint on the intersection of data science, behavioral science, and implementation science, focusing on the developing and testing ways to optimize engagement in the sexual health cascade of care for individuals both living with and at risk for sexually transmitted infections. He's also one of the co-chairs of the ACTG 5418 STOMP study looking at the efficacy of tecovirimat for Mpox disease, which we will be hearing about a little bit later in today's presentation. It's an honor to introduce Dr. Zucker. Thank you.
All right, morning everybody. So thank you to IAS-USA for inviting me. It's really an honor to speak at the Dr. Hammer annual course for someone who obviously was a big part of my life being at Columbia for the start of my career. And it's really a privilege to speak with you today about one of my favorite topics, syphilis resurgent, addressing the growing epidemic from prevention to perinatal impact. I get really excited about this topic, so if I talk too fast, just raise your hands and let me know. But we have a lot of really great stuff to cover today. I have no relevant financial relationships with ineligible companies, and the objectives today are up here on the screen. So I always like to start with the fact that it's important to highlight that we didn't have to be here having this conversation today. In fact, in 1999, there was actually a goal to reduce primary and secondary syphilis cases to 1,000 or fewer in the United States, and the number of syphilis-free counties to 90% by 2005. And the words they said back in 1999 are still true today. As we approach the end of the 20th century, the United States is faced with a unique opportunity to eliminate syphilis within its borders. Syphilis is easy to detect and cure, given adequate access to care. Elimination of syphilis would have far-reaching consequences, including removing two devastating consequences of disease: increased likelihood of HIV acquisition and compromised ability to have healthy babies. With that said, this is where we are in 2023 in the United States. Instead of 1,000 or fewer cases, we have over 200,000 cases, a 61% increase in just the past 5 years. And additionally, we have almost 4,000 cases of congenital syphilis alone, a staggering over 100% increase in the past 5 years. And while syphilis cases are increasing, they are not increasing equally. Rates vary based on age, gender, race, and ethnicity. On the left, you can see syphilis rates by age and sex at birth. In both men and women, rates are highest among younger individuals, with a peak in females during their childbearing years. Additionally, the rate of primary and secondary syphilis is about 3 times higher in men than it is in women, but that doesn't nearly tell us the entire story. On the right-hand side, you can see the rates of syphilis in men, women, and the male-to-female ratio highlighted in bright pink. And it's pretty clear that the male-to-female ratio is declining rapidly. And that's because while syphilis rates are rising in both men and women, they're rising faster in women than men, bringing that ratio down. And what you can see now is that we have more cases of syphilis in females of childbearing age, which is the solid and dashed lines. The more cases of syphilis we see in those age groups, the more cases of congenital syphilis we identify. And that's how we've actually gone from just over 300 cases of congenital syphilis to almost 4,000 cases in just 11 years. And this is not a local problem, although we know New York City has very high rates of syphilis. This is a national problem. The counties in green are considered high prevalence areas where increased screening for syphilis is recommended. These areas cover 38% of US counties, but actually cover 72% of the United States population. Now, I want to start by introducing a case today based on a real patient who came to clinic. It's a couple years ago now, but this is Jack. Jack's a 29-year-old bisexual cisgender man with well-controlled HIV. He's been a patient at the clinic for several years, taking daily bictegravir, emtricitabine, tenofovir. He has one long-term primary female partner and multiple male partners on the weekends. And his last visit was about 2 months before this visit, when he came in complaining of rectal itching and pain. In clinic, we do our exam. Our rectal exam is notable for tender, irregular, ulcerated lesions with induration and erythema. We do an HIV viral load test, as CD4 had been over 800 for quite some time, so we didn't repeat it. We did syphilis testing with an RPR, 3-site gonorrhea chlamydia testing, and lesion swabs for HSV and Mpox. And he declined empiric treatment to wait for test results. So the question I want to start with today is, could this be syphilis? Now, lots of what we talk about today is based on the stages of syphilis, and while many of you may recognize them, I do want to do a quick rapid review. Syphilis progresses through distinct stages. After exposure, the incubation period can last up to 90 days, during which time tests may be negative. And because of this, we always recommend empiric treatment after exposure due to this prolonged incubation period. Primary syphilis follows, typically or classically marked by a painless chancre that can go unnoticed if in a hidden area like the throat, rectum, or vagina. Regional and bilateral lymphadenopathy may actually be the only clue, and a full physical exam is really important for staging and treatment. This stage is highly infectious and classically lasts about 1 to 6 weeks. Secondary syphilis appears 48 weeks later, presenting as a classic rash on the palms and soles, but you can actually have many more systemic symptoms: fevers, lymphadenopathy, chills, fatigue, hepatitis. Without treatment, it will also resolve in about 6 weeks and remains highly infectious. What I want to highlight is, Osler always said, he who knows syphilis knows medicine. And because syphilis mimics many conditions, you really need a high index of suspicion to pick it up. Primary syphilis is not always a single painless ulcer or chancre at the site of infection. We're seeing, and there's more and more reports of atypical syphilis presentations with multiple atypical or painful lesions at the site of infection. Secondary syphilis, as we said before, can actually look like anything. We've had cases with severe lymphadenopathy presenting like lymphoma. We've had cases presenting with hepatitis that were thought to be other types of hepatitis. And so a really high index of suspicion is needed to look for all these varied presentations of syphilis. Latent syphilis, conversely, is asymptomatic, meaning there's no signs of primary, secondary, or other signs of syphilis. If symptoms are present, it's not latent syphilis. And latent syphilis is classified by duration of infection. If you know it was acquired in the past 12 months, it's early latent. Otherwise, it's late latent or latent of unknown duration, which we often classify with late latent. Syphilis testing is most relevant for those without clear signs and symptoms. And that's because in early syphilis, your testing can still be negative. However, frequent screening in asymptomatic populations is important and key to reversing the trends we talked about earlier. And for that, there's 2 screening algorithms we usually use. The traditional algorithm starts with a non-treponema test, most commonly in about 99% of cases now, the RPR. If positive, it's confirmed with a direct treponema test, the FTA antibody, TPPA, or EIA. If they're both positive, there is evidence of syphilis, but remember that evidence of syphilis does not necessarily mean a new infection. It can either be current infection or prior treated infection, which quantitative titers are important for understanding. Conversely, the reverse screening algorithm starts with a direct treponemal test. If positive, it reflexes to the non-treponemal test, like the RPR. And if there's a discrepancy, it actually goes to a third test, another direct treponemal test, to break the tie. Once again, there could be evidence of syphilis infection, but interpreting quantitative titers is critical to understanding whether it's current infection or a prior treated infection. As I said, interpreting these titers is really important. This is an example of an RPR card. It works by mixing patient serum with charcoal-labeled antigens. If antibodies are present, they present with visible clumping in these little circles here, indicating a reactive result. Titers are reported as serial dilutions, and it's a fourfold change that's clinically significant for reinfection or treatment failure. Titers typically decline after treatment, but remember that some patients will remain serofast with persistent low-level titers, regardless of whether they're treated adequately or not. Now that we've covered the testing algorithm, I always get a lot of questions about which algorithm is better or which one should I use. That actually always initially makes me smile because realistically, most providers only have access to the algorithm at their own institution. With that said, it is important that we recognize all of them because we often get referrals or patients coming from outside places where they had a different type of testing than we're used to. The traditional algorithm is more cost-effective. RPR tests are inexpensive and quick, allow for tighter monitoring quickly since it's the first step, and are widely used and understood by practitioners. However, that RPR step, that first step is manual, which means costs can get very high if you're doing a lot of tests. It can also miss early infections and has lower sensitivity in early and late stages. Conversely, the reverse algorithm, the first test is automated, which makes it very cost-effective for labs that perform a large volume of tests, but does require an expensive analyzer, so more upfront costs, but potentially later savings. It also detects early infections better and may help us catch missed cases, but it does require a little bit more complex interpretation that many providers are not yet familiar with. Additionally, treponema titers frequently remain positive for life, making the initial test a little bit less helpful in high prevalence populations. Now, we didn't use them in this case, but there are two other tests I want you to be aware of. On the left, the point-of-care serologic testing for syphilis provides rapid results, reducing time to treatment, especially for populations who may be unlikely to return for follow-up. Point-of-care tests have sensitivities ranging from 50 to 99%, and specificities of 91 to 100, depending on the test that you're using. These tests are FDA cleared and CLIA waived, meaning you can use them in your clinical settings, and they are really useful in outreach settings, emergency departments and urgent cares, field-based screening, and other places where it may be hard to re-engage people after the test is done. On the right, we have the newest thing that's really exciting. In August, the FDA authorized the first at-home syphilis test. This test detects treponema pallidum antibodies with a finger prick blood sample, gives you results at home in about 15 minutes. Sensitivity is over 93% and specificity is over almost 100%. However, both of these tests are direct treponemal tests, which means that they can frequently be positive for life. And so for patients who've previously had syphilis, they can't distinguish between active infection and prior treated infection, meaning that they do require coming into care for additional testing, even if they test positive. On the other hand, for populations that may have a lower prevalence of syphilis, or in settings like pregnancy where people are coming to deliver and haven't been tested before, they have a lot of value as a rapid test that can be done at the bedside or even at home. Going back to our patients, Jack's results returned. His HIV viral load remained undetectable as it had been for years. His RPR was 1 to 32, up from 1 to 4 2 months prior. His 3-site GCCT testing was negative, and his rectal swabs for HSV and Mpox were both negative. So Jack has syphilis. We likely already knew that from his physical exam findings, and that would make his diagnosis really primary syphilis. Everything we've talked about so far with staging really directly impacts how we treat people as well. This slide outlines the current CDC recommendations for treatment, which is determined by disease stage. For incubation, primary, secondary, and early latent syphilis, the recommended treatment is benzathine penicillin G 2.4 million units IM times 1, with doxycycline twice daily for 14 days as the alternative regimen. In late latent syphilis of unknown duration and tertiary non-neuro, it's BPG 2.4 million units weekly for 3 weeks, or doxycycline 100 milligrams twice daily for 28 days. And for neurosyphilis, ocular or otic syphilis, it's IV penicillin for 10 to 14 days. You'll notice I've crossed out the IM option there as it's no longer produced by the manufacturer and so no longer available to us. So I told Jack I wanted to treat him with intramuscular penicillin, and he said, "I'm really sorry. I did that 3 years ago. It's just too painful. I can't do that again." And then he added the kicker, "I also can't take doxycycline. Last time I took it for chlamydia, I threw up everywhere." So he ended with, "Let me think about this overnight and I'll come back tomorrow." And so while he went home, I started to think about what alternative options we could make available to him. There are many options, but there are really 5 alternative treatments that I think about most commonly when it comes to syphilis. Azithromycin has been considered an alternative treatment in the past and was actually in the STI treatment guidelines prior to 2015. Azithromycin is really appealing. It's oral, it's once daily dosing, we use it in pregnancy. However, resistance to macrolides is common, including azithromycin. A recent New England Journal article highlighted just how widespread this is, showing near universal resistance in North America. And because of this, azithromycin is actually not recommended for treatment of syphilis. Linezolid is another option that's been thought about for syphilis treatment. It's also oral, which makes it really appealing. However, a recent study done in Spain that looked at linezolid 600 milligrams once a day for 5 days found that it did not meet non-inferiority criteria, meaning it should not be used for early syphilis treatment. With that said, there certainly are questions remaining about whether if we dosed it for longer or dosed it twice daily instead of once daily, if it would be more effective, and there is a study ongoing to look at that. Amoxicillin is a really interesting one as an alternative to syphilis treatment, with or without probenecid. One really interesting thing I learned fairly recently was that BPG was actually not available in Japan until pretty recently. And so they had been treating their patients with syphilis with amoxicillin or amoxicillin plus probenecid. They actually did this recent study that looked at comparing amoxicillin, high-dose amoxicillin plus probenecid with lower-dose amoxicillin. And they actually found pretty good serological cure rates. Low-dose amoxicillin, the overall cure rate was almost 91% and 93.5% in early syphilis. With amoxicillin plus probenecid, 94.4% and almost 98% in early syphilis. And they did not meet their non-inferiority criteria, saying that you could use either of these options for early syphilis. And so amoxicillin is an interesting option available. Cefixime is another interesting option. It's a third-generation cephalosporin, and it is being explored as a potential future alternative for syphilis treatment. There's oral data from this 2-arm non-comparative pilot study that suggested that Cefixime participants were cured in about 87% of cases, although as you can see with an extremely wide confidence interval due to low sample size. There is a larger study ongoing in Brazil right now by the CDC and WHO that's really going to look at Cefixime's potential role in treatment among men who have sex with men. With that said, I'm not sure of the current status of that study given everything ongoing at the moment. Finally, ceftriaxone. So ceftriaxone is a third-generation cephalosporin as well, and it's been actually recommended as an alternative syphilis treatment in Australia by the WHO, by European guidelines, and it's even included as a potential option by the CDC in the 2021 STI treatment options. Unlike BPG, ceftriaxone has a much shorter half-life, which means it requires daily IV or IM administration, 10 days for early syphilis, 10 to 14 days for for neuro-ocular or otic syphilis. And the truth is the dosing and duration of this is just not well established, but it does remain a potential alternative when penicillin is unavailable or contraindicated. So back to Jack. So Jack actually did not come back the next day. I know, he'd been coming to me forever and then just didn't answer my text. So 1 week later, he felt like he was having a hard time hearing the TV, and he actually went to an unaffiliated ED close to where he lives, where he was seen by ENT. They said that he had asymmetric hearing loss and should get an MRI. He actually got the MRI, and it was totally normal, and they just said to follow up outpatient. About 3 weeks after that, he felt like he was having a hard time seeing the TV. He went back to the same ED where he was seen by ophthalmology. They diagnosed him with panuveitis, and per their note that I actually saw, wrote, "Send a panuveitis workup." I don't know what's in a panuveitis workup other than RPR, quant gold, and probably some autoimmune things. But we certainly see a lot of RPRs and quant golds in ID clinic for the panuveitis workup. And they told him to follow up outpatient. At that point, he finally texted me back. So I do want to highlight ocular and otic manifestations of syphilis. So we see a lot more of these than we used to, probably because we're seeing a lot more syphilis. Remember that ocular and otic syphilis can actually occur at any stage of syphilis. Ocular most commonly presents as panuveitis, which should sound familiar right now, but can actually involve any structure of the eye, anterior or posterior structures of the eye. Otosyphilis typically presents with cochleovestibular symptoms, including tinnitus, vertigo, centroneural hearing loss. And it can be confusing because it can be unilateral or bilateral. It can have a sudden onset or a slower onset, and it can progress rapidly. I want to emphasize the fact that both of these things really are medical emergencies. They can lead to permanent vision and permanent hearing loss without treatment, and so we really want to be on the lookout for these in our patients who may have syphilis. Kings County in Washington State developed a really great questionnaire that we use in our clinic that we use to screen people who either have syphilis or may have syphilis to see whether they have any symptoms of otosyphilis, ocular syphilis, or neurosyphilis, and may need additional treatment. So Jack called me, or texted me back, and then he came into clinic. And the question is, does he need an LP? This is always the big question, is if people have ocular or otic signs, we're pretty convinced that it's neurosyphilis, and we're gonna start them on IV therapy. Do they need a lumbar puncture? And the answer to that is no. The 2021 STI treatment guidelines really recommended fewer lumbar punctures. They really only recommend LPs in the following cases: in patients with other neurosigns and symptoms, to rule out other causes of those symptoms. In tertiary syphilis, because about 40% will also have neurosyphilis, and it can potentially change your management. And then in asymptomatic patients with a fourfold increase after appropriate therapy, and those with high titers that fail to decrease fourfold, again, because it may suggest that you need to do IV therapy and may change your management. Otherwise, there's really no recommendation to do lumbar punctures. For Jack, as we mentioned before, he's gonna get IV therapy for neuroocular otic syphilis, in this case, ocular and otic syphilis. In terms of alternative options for neurosyphilis, ceftriaxone is probably the most reasonable and the one that the CDC guidelines say to consider in consultation with your local infectious disease doctor. It has been studied a little bit. There's this study from France with a retrospective multi-center study that demonstrated really good outcomes. The biggest challenge around that is that they do need IV therapy for 10 to 14 days and can't necessarily get IM unless they're willing to come in every single day. Doxycycline is another interesting alternative option for some patients. You know, we do use it for neuro-Lyme now, and we know that it has good CNS penetration. We just really don't have enough data on clinical outcomes in people with ocular, otic, or neurosyphilis to really be comfortable using it at this time. In terms of managing people living with HIV and syphilis by status, you know, testing and treatment is identical. Some things to think about, though, for people living with HIV. Titer response. Titers may actually take longer to decrease fourfold in people living with HIV. In terms of the risk of neurosyphilis, people with HIV may have a higher threshold or lower threshold for getting neurosyphilis, and so we need a lower threshold for CSF evaluation and really making sure we screen these patients for symptoms of ocular, otic, and neurosyphilis. And then serologic follow-up is actually recommended more frequently due to the slower titer decline. And so back to Jack. Jack called me after his visit to tell me everything was going on. We talked about his options, and he actually had a midline catheter placed at home and completed 14 days of IV penicillin. But there's always one more thing. And he said, oh, what about my female partner, Jill? You know, we talked about her coming into clinic to get treated. He'd left out the part that she's 16 weeks pregnant. It's always something. And so this is our opportunity to talk a little bit about congenital syphilis, which I mentioned earlier really is increasing rapidly. So Jill's a 28-year-old woman. She's Jack's longtime primary partner. She's been a patient at the clinic for several years and is taking TDF-FTC for HIV prevention. She's 16 weeks pregnant, and she has no current symptoms, but is coming in for evaluation. So why are congenital syphilis cases rising? Well, there's a lot of reasons, but number one is inadequate treatment. So even when we make the diagnosis of syphilis in pregnant persons, we're not adequately treating people. The second is no timely test. We're forgetting that females, and particularly pregnant females, can acquire syphilis, and so we're not testing them regularly. And those are far and away the two biggest reasons that congenital syphilis cases are rising. And to reverse that, we need to understand and treat syphilis adequately, and we need to increase the number of people that we're testing. To assess for congenital syphilis, it actually involves both the mother and the baby. It starts by identifying syphilis in the mother. And as a reminder, the syphilis testing algorithm does not change just because people are pregnant. We test them the exact same way. One thing to know, though, is that false positives are more common in pregnancy, and a positive low-titer non-treponemal test can be considered a transient false positive. If confirmatory testing is negative, the patient is asymptomatic and at low risk for infection. Repeating the RPR in these patients is unlikely to be beneficial because it can last for 6 months, and they should have follow-up after delivery to ensure that the RPR resolves. I will say that we have a very low threshold these days for treating people in pregnancy and need to be really convinced it's a false positive before we would say that. Jill's workup, her exam was unremarkable. We did our standard STI testing, and we gave her 1 injection of BPG, IM times 1, for presumed early latent syphilis, or for exposure to syphilis. Her results came back. Her antibody antigen test was negative for HIV. Her RPR was 1 to 16, up from 1 to 1 6 months ago. And she had 3-site GC-CT NATs that were negative as well. So was 1 injection of BPG enough? You know, we said before that for exposure, early, secondary, and early latent syphilis, 1 injection should be enough. However, forgot to mention this, pregnant women, so in terms of treatment for pregnant women do not have an alternative option for treatment. It always needs to be penicillin, and pregnant women who have a history of penicillin allergy should be desensitized and treated with penicillin. Otherwise, the treatment algorithm is the same, except for what I was about to say before, additional therapy in pregnancy. So, you know, we don't have a lot of great data and great PK on penicillin in pregnancy. And so there's certain evidence, which is really PK evidence, that additional therapy is beneficial for pregnant women to prevent congenital syphilis. And for women who have primary, secondary, or early latent syphilis, a second dose can be administered 1 week after the initial dose. And I frequently do that for people, especially in the 2nd and 3rd trimesters. The other caveat and the other thing that's a little bit different for pregnant persons is days between doses. For pregnant persons, missed doses greater than 9 days are not acceptable. For pregnant women receiving therapy for late latent syphilis. And if they miss more than 9 days, they really should be restarted and start the entire 3-set series all over again. Going back to Jill, so Jill had an otherwise uncomplicated pregnancy and gave birth to a healthy baby at 39 plus 3 weeks gestation. She was retested monthly and her RPR titer by delivery was down to 1 to 2, which is really awesome. And so we do have to also assess syphilis in the neonate. So we've covered syphilis in the mother through the standard testing algorithm with a high rate of false positives. We've talked about maternal treatment being adequate, the same treatment algorithm, but a possible additional dose and less forgiveness for missed doses. But we also have to look for syphilis in the neonate. So the pathophysiology of congenital syphilis is actually really fascinating. At its onset, spirochetes enter the circulation. They can actually spread to nearly all organs. And around 20 weeks of gestation, when the immune system starts to develop, you can get an inflammatory response in these organs, and that actually leads to the clinical signs and symptoms that we see. Because it can affect any organ, the clinical signs and symptoms are really varied, and they're actually well described in this picture from the New England Journal here. Most commonly are things like jaundice, hepatitis, and other things like that, but they can be virtually anything. And a thorough physical exam of the neonate is really important to help understand whether congenital syphilis is possible or not. In addition to signs and symptoms, we also look for lab evidence. These can include subtle abnormalities like anemia, thrombocytopenia, leukopenia, or leukocytosis, as well as less subtle findings like an elevated WBC or protein in the CSF or reactive CSF VDRL. Finally, there are radiographic findings that are highly suggestive of congenital syphilis and are an important part of our diagnostic workup. Some of these findings are periostitis with irregular periosteal thickening, metaphyseal serration, and demineralization and destruction of the upper medial tibia. Finally, the last part of assessing congenital syphilis is comparing maternal treponemal and non-treponemal titers. Testing should be done using a neonatal serum RPR, not cord blood, as maternal antibodies can cause misleading results. A greater than 4-fold higher neonatal titer than mother's titer is suggestive of congenital syphilis. Using all the information we've just discussed, you can classify the baby into one of 4 scenarios: proven or probable syphilis, possible congenital syphilis, less likely or unlikely congenital syphilis. And each of these categories helps us understand what additional evaluation and treatment is needed to ensure the best outcomes for the infant. I did provide the criteria for diagnosis and recommended evaluation as extra slides, but won't cover that today in the interest of time. We're not done yet, though. So about a year later, they had come in intermittently, but about a year later, Jack and Jill came in together for routine STI testing. They report no sexual activity with each other, except with each other, since the baby was born due to how much work having a baby is. Jack's RPR was 1 to 16. It was 1 to 32 previously. Jill's was down to 1 to 1. And so I do want to use this to talk about how to manage serological non-response. You know, we're over a year later, actually almost 18 months later, and the titer has not come down fourfold. So is that a problem? And for this, I have this amazing thing that Khalil Ghanem has lent me, which is one of the best ways to describe managing serological non-response. The first is always starting with are there any neurological, ocular, or otic signs or symptoms? He had these before, but didn't have them now. If yes, we're going to treat with IV penicillin. If no, did we wait long enough for the titers to decline? And this is where this case gets tricky. In primary or secondary syphilis, we'd expect titers to decline in 6 to 12 months. In early latent syphilis, we'd expect titers to decline in 12 months. Late latent, we expect them to decline by 24 months. And we know that it can take longer in HIV-positive individuals. In this case, he had secondary syphilis with neuro and ocular findings, and we're 18 months in and his titer has not declined all the way. If we haven't waited long enough, we should just wait longer. There's no need to retreat if we've not waited the right amount of time. Did the patient get reinfected or is the patient pregnant? This is always probably the most likely reason. If yes, we should retreat them with benzene penicillin. If no, is the titer greater than 1 to 64? If no, we should consider an LP. Sorry, that should be if yes, we should consider an LP. If no, we should keep following the titers. Now I know lots of providers like to retreat at this point, but there is no evidence or any benefit to added treatment. So as a reminder, there's no need to retreat here. If you feel like you have to do something and you have to retreat, please retreat only one time, as we see many, many patients who come to us after 9 or 12 shots of BPG. And so only one time and then stop. If they're not going down, they're not going to go down any longer. And there are many studies that show there's no benefit to further treatment. And with that, I am really out of time. I just want to remind everyone that we can prevent syphilis in the first place through STI prevention. We have primary prevention with condoms, risk reduction counseling, and medication prophylaxis that you'll hear about next. We have secondary prevention with routine screening, syndromic testing and treatment, presumptive treatment, and even partner services. And with all of these things in place, we can reduce the syphilis epidemic. And thank you very much.
Thanks, Jason. That was really phenomenal. We've got a couple of questions online. Hopefully some of you have questions here in the audience are writing them on question cards. Please put them on your cards and we will have Dr. Zucker answer them. Just while we're waiting for questions to come up, Jason, you didn't weigh in on had he agreed to oral treatment, Jack, your patient, at that time. Which of those options would you have gone with? Would you have gone with, you know, the unstudied BID linazolid? Would you have done cefixime? Would you have done ceftriaxone, amoxicillin with or without? What would you have done?
So I would have really liked to convince him to try doxycycline again with an antiemetic. I mean, that would have been my first choice. We have the most data on doxycycline as an alternative regimen. Is this working? Can you guys hear me? Okay. We have the most data on doxycycline as an alternative regimen. If not, the next thing I probably would have done is amoxicillin. I think, you know, we don't have US data, but that Japanese study is pretty convincing and showing high 90s cure rates, including in people living with HIV. So that's what I probably would have done if I couldn't do that.
So is that 3,000 milligrams a day?
So you can do 1,500. I mean, the study showed 1,500 was non-inferior to 3,000 plus probenecid. So I probably would have done the 1,500.
Great. A couple of questions about the issue of whether you think, or in general, had your patient been treated right away with BPG, do you think the optic or otic complications could have been avoided, or do you think they were brewing already and would have manifested later?
So he didn't complain of any ocular or optic complaints at the time I saw him. So my suspicion is had we been able to treat him early, we may have been able to prevent it.
Great. Can syphilis be transmitted in breast milk?
In breast milk. Certainly if there's lesions on the skin, it can be transmitted that way. I actually do not know, looking to Elaine over there, if it can be transmitted in breast milk itself. I actually don't think so. She's shaking her head no. I don't believe so.
Great. When you have a concern for otic syphilis in particular, and I guess we could generalize this to eye disease as well, when you refer to a specialist and you're already treating, what are you looking for? Or what would an ENT be looking for to help either confirm or refute the diagnosis, you've already initiated treatment.
Yeah. So baseline hearing, so you could see whether or not it's what it is at baseline the time you're starting treatment, and then if there's any deficits, whether it improves after treatment. And the same thing with ophthalmology, you know, looking for evidence of panuveitis, vision issues, and then you want to be able to evaluate over time whether they improve. You know, one of the challenges for subspecialists, if you send it to them after, they don't know whether the patient's actually getting worse or better. So getting a baseline at that time is really helpful.
Great. And I think you had answered this or at least referred to it in your talk, but people are just wanting to confirm, can in fact otic or ocular disease happen at any stage of syphilis infection?
It can happen at any stage of syphilis infection.
Excellent. Great. Okay. A couple of people, of course, have very specific questions about cases. We love this. You know, it's the what would you do situation. So you have someone with newly diagnosed syphilis in a psychiatric patient with low titers, 1 to 2 or 1 to 4, who's gotten treated already with 3 IM doses of BPG. How would you follow up and what would you do, if anything?
Yeah. So, you know, age matters a little bit. We know that RPR titers decline over time. And so an RPR titer of 1 to 1 is relatively low, and in an older person, that could certainly be time. If they're a much younger person, it would make me think less about that being the primary cause of their neuropsychiatric issues. You know, these cases are always really challenging, right? Because, you know, diagnosing neurological or psychiatric illness is challenging. We don't necessarily have good definitive blood tests and other things. And so if psychiatry is putting syphilis on the differential as something that they seriously think, and I often have a conversation with them, seriously think could be in there, then we will work it up further. But the goal is ultimately to either do a workup and figure out whether they need treatment, or to offer them treatment one time to sort of take that off the table and remove that from the differential diagnosis.
I think that comes up a lot, especially in the inpatient setting,
Yes.
right? Someone with altered sensorium,
That's right.
sometimes an older person, you know, neurosyphilis is on the diagnosis of altered sensorium,
Yep.
and then you have to be careful what you ask for, right? Because you send the RPR,
That's right.
and you have to deal with it. Okay, so in that vein,
Yep.
I'm going to assume that this is a reverse algorithm question. Whoever asked this can clarify if I'm getting this correct. Positive treponemal test,
Okay.
negative RPR,
Yep.
older married person's wife is negative and asymptomatic. By negative, I assume all syphilis testing negative. Treat or ignore?
Well, we're missing a test still. So, you know, in the reverse algorithm, remember, it starts with the direct treponemal test, which was positive in this case. Then it went to a negative RPR, is that right?
Correct.
Then a negative RPR. So there should be a third test to rule it in or out, another direct treponemal test. Now, the history sounds like it's a person who is less vulnerable to HIV maybe than others, and so you would not necessarily expect it. But again, the RPR can decline over time and can even become negative if it takes long enough. And so if this is someone who has never been treated for syphilis before, you do at least need the third test to complete the assessment.
I think that's something that's often missed when people think about the reverse
Yep.
algorithm, is that when you get this discordant result,
Yep.
you do need that third test.
That's right.
Right.
I think that's the challenge with the reverse algorithm, is we're just less familiar. It's been around for a shorter period of time, and people aren't as familiar with it.
So here's a question I think many people in this audience, and I know I face all the time. You know, you've got titers that either aren't responding or, you know, are sort of low grade positive for long periods of time, and you have somebody who's always at exposure risk. How do you sort of triage that in your thinking?
Carefully. You know, one of the challenges we had for a while was the BPG shortage, right? So really thinking about that in the setting of a true drug shortage when we didn't have enough medication for people we know needed it is hard. You know, if they have low-level titers and they're coming in regularly for testing, if they were reinfected, we would expect the titer to come back. I certainly have a lower threshold for treatment in those people. And, you know, we say 4-fold increase represents reinfection, but for some of those people who are highly vulnerable and, you know, tell me that they have multiple partners, some of whom had syphilis and other things, we'll often treat them with a 2-fold increase because we're worried. But it's, again, trying to balance the risks and benefits of treatment with the individualized and personalized sort of assessment.
Great. Here's a question I know we get all the time in our practice, and I'm sure you do as well. RPRs being a manual test likely to differ across institutions and labs. Somebody gets referred to you, for titer X, and you repeat it in your system, and it's different. And, how do you interpret RPR titers and/or apparent changes across laboratories?
I mean, it's not just laboratories, right? It's a manual test. It's across technicians within your own lab as well. And so I treat it sort of the same way, as we have to take the result as it is. If I find it wildly divergent, I will often repeat it just to see sort of, do my two results look the same in our same lab, or do they look wildly different and one looks more like the other lab? And that's happened before. And so if they're wildly different, I'll repeat it. Otherwise, I'll just sort of interpret them as best I can.
Great. You mentioned, but didn't get into details about prozone. Yep. What are the clinical circumstances in which you would be on the phone with your lab saying, I'm suspicious, can you do extra dilutions?
Yeah, so it goes both ways, because in many of those circumstances, people are telling me that they were exposed and I'm going to be empirically treating them anyway. So the prozone is a little bit less valuable in those cases. I think the ones that are most valuable is when people have vague signs and symptoms, maybe don't have the rash, but have hepatitis or some other secondary syphilis symptom, or lymphadenopathy, and I suspect syphilis, but the RPR came back negative. I'll call the lab and ask them to dilute it out.
Okay. So I have a feeling we're going to be talking about this question a lot more after Dr. Blair's talk, but do you want to sort of presage the answer to this about someone who's using doxycycline for post-exposure prophylaxis? Does it change the way you think about the interpretation of syphilis testing results and titers?
I don't want to step on Dr. Blair's presentation. I worry about it a lot, but I don't think we've seen evidence of exactly how it does that yet. So, we've seen in HIV what early treatment can do. We don't exactly know what will happen with early treatment or with doxy-pep. And so I think a lot about it a lot, but I have not changed my practice in any way so far.
Great. And we have a question here at the microphone.
Hi, my name's Eamon Vitt. I'm an HIV specialist. Thank you for the STOMP trial. We spoke recently about that. Okay, so I work downtown New York. I'm going to speak about the shortages. Okay, so I'm the guy, I don't mean to sound grandiose, but Paul Sachs interviewed me about a successful project where I convinced Mark Cuban from Cost Plus Drugs to import the equivalent of Bicillin from Europe. Okay, so right now, Cost Plus Drugs is selling it for $30 a dose. The pharmacies around this neighborhood, $500, $600, $700, $800 a dose. Okay, so we all really need to be aware of the price gouging that Pfizer has engaged in for decades. There's a monopoly, and there will be allusions to the current administration throughout the lectures today. It's a very serious situation. 340B program could disappear in 6 months. We have no idea. The worlds we all work in is chaotic at a baseline. It's going to get worse. So I think generic pricing, it's super important that we're all aware that you can get affordably priced generic drugs. I take no money from Mark Cuban, but Cost Plus Drugs is really stepped up and helped the communities that we served. And so check them out. Thanks.
Thank you. And with that, we're out of time, but we want to thank Dr. Zucker very much for that tremendous talk.